So should we start?
Sure. Welcome to Math 119-312, Mathematics of Pandemics. Today we're hearing about flattening the curve, which I believe, according to theory, should have happened sometime in early April.
Yeah, so we are the Flattening the Curve group. Just like Professor Miller said, we've been pushed back here and there, which is, I guess, somewhat fitting for our group that we're trying to talk about the curve and ways to flatten it. And so, our strategies get pushed later and later semester, but we're here now and we're excited to share what we have with you. So we'll dive right into it with my partner, Maria, who will be talking about some of the background and motivation.
Yeah, so I'm going to be talking a little bit about what it means to really flatten the curve from like a social standpoint, and also like the feasibility of it, and how it relates to healthcare infrastructure. And so, yeah, so we've seen this graph quite a bit before, especially at the beginning of the shutdown. I remember for my own, like for myself, when all the classes were shutting down, this is what all the professors were showing and like saying, yeah, this is why we're shutting down the schools. And it kind of made sense, but I thought it was worth it to just explain what it means to flatten the curve. So what we know about flattening the curve, or what we've heard before, is just preventing like the overwhelming of the healthcare system by using social distancing and stay-at-home measures. But something that a lot of the times is not really discussed when we talk about flattening the curve is the idea of the healthcare system capacity. So when we are considering where to flatten the curve to and whether it's feasible to flatten the curve, we have to think about how our healthcare system can handle new cases, and what kind of protective measures can be taken depending on what the healthcare infrastructure is of the place that we're considering. So how do we measure hospital capacity and healthcare infrastructure is a big question when it comes to flattening the curve. And so a lot of the times what we think about when it comes to flattening the curve is the availability of tests, beds, ventilators, personal protective equipment for healthcare workers. But other things that should be considered when it comes to flattening the curve are having enough capital, equipment, and the production capability to maintain an increased demand in health services and products. As the pandemic grows, it's important that whatever place that we're in is able to create more masks, or create or produce more ventilators, or just whatever supplies are needed, the place needs to be able to produce them, or access them somehow. And then also other things to consider when it comes to flattening the curve and the infrastructure of the healthcare system are the accessibility to care, and whether people can access a doctor, whether they can pay to go to a doctor or take off time from work, either for the idea of staying at home or also to prevent the spread of disease, and also their level of comfort with going to a doctor if they think they're sick, and also the availability of healthcare workers and technology and telehealth services, especially, so that people are not like going to the doctor necessarily. So these are all things that should be considered when it comes to flattening the curve and where to flatten it to and whether it can be flattened. So that begs the question of where the US stands when it comes to infrastructure and hospital capacity. And the answer to this question will really determine what government regulations are suited to flatten the curve. So here is a graph by the OECD showing the percent of GDP that goes into health spending in different countries. And if you can see here, the United States is the country that spends the most in healthcare out of any OECD country. 16.9% of our GDP in 2019 went into healthcare. But what exactly does this mean? Is this like a good thing or a bad thing? Well, it depends, but here is another graph by the OECD showing what a relation between life expectancy and health expenditure. And this is also the case when it comes to preventable diseases, but the general trend is that the more you spend in healthcare, the more you can sort of expect life expectancy to increase. But then when you look at the United States, that's really not the case. We are the country that spends the most, and also we get pretty average results when it comes to life expectancy, and same thing with preventable deaths and diseases. So that's something to consider when it comes to how we're spending our money on healthcare and how it relates to whether our healthcare infrastructure is suited to prevent an outbreak such as COVID. So yeah, so the US is an outlier. And so that means that the high health expenditure is not as related to infrastructure and hospital capacities and the ability for us to prevent disease as much as it is that our healthcare costs are incredibly high, and they grow way faster than the consumer price index, which means they grow faster than most other costs of living. And so some possible reasons for this are that there are just a lot of administrative structures that are really complicated in our healthcare system compared to other health systems. And that leads to a lot of redundancy and resource waste. And then another possible explanation is that the US also has a lot of hospital monopolization and lack of competition. So that could also lead to a lot of waste in resources and a lot of high costs of healthcare. And so when you look at another measure of how we're doing when it comes to our healthcare infrastructure, which is capital expenditure on health. So this is machinery, which is like how we can keep up with the demand of healthcare or technology or things of the sort. You can see that the US doesn't spend that much on capital expenditures in health. So what that means is that there really is just not as much spending in equipment, or there was not as much spending in equipment before the pandemic, and in technology and human resources, to really have a strong foundation of the healthcare system. And part of the reason for this is that there's a steady decline in the availability of grants and other sources for funding. So a lot of hospitals actually sort of have to rely on going into debt to finance capital investments and things of the sort. And so one way that we can kind of see this, and there's plenty of examples, but a really important one is when you look at the average age of plant index for hospitals. So that means like how updated a hospital is at a given time. In the past like 20 years, the median average age of plant has increased in hospitals by 3 years, which means our hospitals are like getting older and that they're not getting as updated. And there's also just a lot of disparities, which I'm going to go to in a little bit, in the regions and by different regions and neighborhoods and things of the sort. So that means that not only are we spending way less on capital, but also different places can have various different capacities, which will impact whether they can really handle a pandemic such as COVID. So some other factors to consider are regional disparities. So the US has a lot of different types of regional disparities. So this is a map of testing deserts, COVID-19 testing deserts in the United States. And many different sources that we looked at have found that rural counties have like a way higher instance of not having enough tests, not having enough hospital infrastructure, and also they have been the places that have been most heavily impacted by COVID. And this was already sort of happening, before the pandemic. Rural counties already had way more premature deaths and instances of preventable disease. But the pandemic just sort of like continues to reinforce the fact that the healthcare infrastructure in these areas just was not equipped to handle something like COVID. And then there's also a lot of disparities between cities. In some cities, life expectancy can range between like as much as 25 years from one neighborhood to the next, which means that some areas in a city can have like a lot of accessibility to healthcare and other areas not as much. And there's a lot of reasons for this, including whether the people in a certain neighborhood feel comfortable going to their local hospitals, whether they're working overtime and they can't like access the hospitals or a doctor because they just don't have the time to go and get checked for whatever reason. And so there's also disparities between cities, and then there's also a lot of racial disparities, and there's a lot of predisposing conditions that can be very different depending on a person's ethnic or racial background. And these conditions can also then impact how likely someone is to get COVID, and also um, people who are of minority backgrounds are more likely to live in areas that are highly underserved and have lower healthcare infrastructure. So that's also something to keep in mind. And so something that we were thinking about, and something that a lot of studies talked about, was the fact that it's really difficult to separate between geographical and racial disparities, because those are often like very linked. And so when it comes to healthcare infrastructure and preventing the spread of COVID, you have to sort of consider, can people access the doctor? Can people stay home? Can people actually follow whatever mandates are placed by the local governments? And it's something that needs to sort of be taken into account when we look at all of these graphs and all of these models, is like, how do we implement this in the real world, and where are the disparities, and like how we could feasibly do something compared to in one place compared to another. And then finally, there's also a slight shortage of doctors and nurses and other health professionals. And there are many reasons for this, but a big one that was happening before the pandemic was an increase in the aging population, which is also just highly relevant to COVID, because not only did we already have an increase in the aging population that was causing the shortage of that was one of the leading causes of the shortage of doctors in the US, but it is also important in that this population is also more likely to need care for COVID. And so just thinking about who's more likely to need the care and where are these resource disparities is important. And then this is just, the link is below, and we'll share the slides, but this is just a really cool interactive map that you can go to. And it basically just shows you, you can kind of edit what you want to see, like based on like the amount of deaths in a certain county versus like the hospital beds per 1,000 people versus like health factors and members at risk. And you can like actually see just how different like all of these places are when it comes to how people are handling the pandemic, how the hospitals are able to keep up with that. And it's something really fun to play with, and just like something to notice just how many different ranges of disparities there are. And yeah, so just as a quick recap in relation to flattening the curve, preventing the spread of disease and being able to treat a large volume of cases really does require a strong healthcare infrastructure. And the US kind of faces a problem in that the investment in capital and healthcare infrastructure in the country had already been on the decline before the pandemic. And healthcare costs are really high, and they're just not equal among all populations. And in addition to disparities related directly to healthcare, certain populations just may be less able to follow stay-at-home orders, have access to care and testing, and so it's really it makes it difficult to prevent the spread of disease. And so the measures that must be taken to flatten the curve will depend on the resources available in the region and the population's ability to comply with mandates and regulations. And so in the next few sections, we're just going to consider the calculations that have been made so far and what we have found when it comes to the effectiveness of current measures. And so I'll leave it to Justin for the next section.
Right. So now that we've gotten some insight into the social reasons and issues that can get in the way of flattening the curve, it's a good idea to kind of look at it from a theoretical perspective of what the curve is when we're talking about it in a media sense, as well as how effective the main strategy that we're looking at, which is social distancing, really is. Next slide. So throughout the pandemic, we've been told about this curve of the virus that we need to flatten to gain control of the situation. And from the slides before this, we've seen just how important it is to get this effect into place in our country. And so what is this curve when we actually look at it from a mathematical perspective? Next slide. So the curve itself just refers to the shape that we see when we look at all the cases over a certain number of time steps. And so there tends to be a natural bell curve here. And when the media is talking about flattening the curve, all they really are talking about is the maximum height. And all the maximum height is at any given time point, we want to just look at what's the maximum number of newly infected individuals. And this is the number that they use to consider whether or not these hospitals are going to be at a capacity and things like that. So the focus isn't really on the total number of infected individuals, even though that is really important, but rather the peak of how many people end up getting infected at a single time point. Next slide. When we were researching flattening the curve or flattening the peak, we actually ended up seeing two perspectives. The first was somewhat more isolated, and it's only in one of the studies that we'll be looking at today, and is that the total volume of infected individuals will remain the same, but still have strategies to have a lower max height. Whereas the second perspective, which is somewhat more common, has strategy where not only are we going to lower the peak of individuals infected, we're going to lower the volume of individuals affected as well. And this is more in line with what we'd expect to be important, that not only do you want, the maximum number in any given point to be lower, we just want less people to get sick overall. In both, most of the strategies and models that they ended up looking at extended how long the pandemic lasted overall. So for example, this model that we're going to look at now originally had an eight time step pandemic, but when they enacted their strategy to lower the peak, they ended up making the pandemic itself last for 13 steps, they are able to get a lower peak in return. Next slide. So the first study that we'll be looking at took the approach where the total volume has to remain the same. And so the strategy that they used, social distancing, was applied to basically a map of all the people who are going to be infected and the people around them. And they used a graph to represent the interactions that they had on a day-to-day basis, as well as the relative distance from person to person. So in these graphs, the nodes or dots are people, and these edges are how they're connected to people, relative densities of communities as well. So in the first graph, we see that there are a lot of edges. People are pretty close together. We see a lot of clumps where people interact with each other quite often. And so this is the quote unquote normal situation where the pandemic just has this regular looking peak and then slowly curves down until the 8th time step. But in the second graph, what they did was they enacted a social distancing based off a couple of different strategies. The first that we'll be exploring in today's talk actually just has people relatively isolating themselves from everyone. They did look at a couple other situations where they would isolate from just within their community, et cetera, but for the purpose of showing that the peak does go down, just from a purpose of graph theory, by extending how long it takes for people to interact with each other, by seeing how long it takes to get from patient 0, who is our little red square, to the little blue dot way in the left corner, can be really, really extended, just by having people talk less, be a little further away from each other. And so we'll still see everyone get affected eventually, but it'll take longer and we'll have much lower peaks, which lets the healthcare system do its job. Next slide. The next study that we looked at the effects of different levels of social distancing. And in this study, they took relatively simple parameters where they just fixed the how long the quarantine period was, as well as how effective the disease was against humans, and worked off of these same parameters for each of the levels of social distancing. So this model looks at around 5 different levels of social distancing. So the red peak refers to 10 people contacted per day, and lowest, the orange peak, refers to 6 people contacted per day. And as you might expect and hope, considering that this is their main strategy, as the number of people contacted per day went down from 10 to 6, we saw the infection rates decrease. And the slightly surprising conclusion we come from this study is that unlike in a lot of situations where the solution can be measured almost a sliding rule, where we see how harsh are we willing to be about this solution, whatever it may be, often we run into diminishing returns where the next unit of solution isn't actually as helpful as the one before it. But in this case, the stricter we are with social distancing, we found that the more that people social distance, the study also reports that the percent infected goes down even more than the previous step did. So here we actually have increasing returns, and the harsher we get, the better it's going to be for each additional person you just don't interact with on a day-to-day basis. Next slide. So this last study that we're going to look at needs a little bit of background that refers to the CDC itself, and I'm going to let my partner Andrew take this part.
Yeah, so for this next part, we looked at a CDC study that analyzes the effectiveness of social distancing interventions and specifically only social distancing. So it takes a look at 4 different scenarios of social distancing, specifically in the city scope. So it takes a look at an example city, and we have 4 cases. The first one is to protect vulnerable populations. In this case, the vulnerable population is defined to be adults older than 60 years of age, and we'll have them reduce their contacts by 95%. The second scenario is that we'll protect the elderly and close schools. So in this case, the elderly and children will reduce their contacts. The third case is restricting the elderly and young adults, but will keep schools and essential businesses still open. So in this case, the elderly and young adults will reduce their contacts, but children won't. And the last scenario is more akin to our real world scenario at the time of the study, which is about August, in where everybody will social distance. So this is with schools closed and non-essential businesses closed. So next slide.
It sounds like somebody else has their audio on, so I'm going to just quickly mute everybody, then unmute, and then just unmute yourself.
Okay. Can we go to the next slide?
Give me 1 second. It's not clicking. Give me 1 second.
Okay.
Sorry.
We're just in some slides we can show.
Okay, cool. So one thing that this study looked at was the timing of social distancing, specifically a 42-day social distancing mandate enacted on the 4 different scenarios. So in these graphs, we'll see 4 or 5 different colors, and each of those represents the different scenarios outlined in the previous slide. So in all 4 of these cases, we start social distancing 50 days after the first case is reported, and everyone will stay social distance for 42 days. From A to D, we have an increasing infectious period assumed for the spread of the virus. And we can see that regardless of this infectious period, when we start our social distancing this early, so to speak, there's hardly any change in the peak of these graphs. So one takeaway of this is that early interventions only delayed the pandemic, since we don't really see a flattening of the curve when we start too early and end too early. An important thing to go back. An important thing to note is that this study doesn't include any of the other interventions like I mentioned. So when they say the social distancing period ends, they're assuming that contacts will go back completely to normal as they were before the social distancing was enacted. Okay, next slide. And then they did another study where they tested a delayed intervention, since the models for an early intervention proved that there probably wouldn't be any significant improvement or flattening of the curve. So in these graphs, A, C, and E represent an early intervention that we saw previously, and B, D, and F represent the delayed intervention, where we're now starting the social distancing rules 80 days after the first case instead of 50. The top 2 are a 25% contact reduction, C and D are a 75% contact reduction, and E and F are a 95% contact reduction. And now I'll let Justin talk about the results of this study.
Right, so just like Andrew mentioned, that first style of social distancing when they did it at the very beginning of the pandemic didn't really do anything. But right away, we can look at graph B and notice that if they move the timing at which they put this 42-day quarantining at the middle of the pandemic, so right at around 80 days after first case reported, but for us, we can just interpret this as the period in which we would have seen the peak of the curve. they notice that each of the curves goes down by a good amount compared to what it was before, with the blue curve being our standard to kind of see how much they went down by. The paper then mentions that if they actually do this 25% reduction that we're looking at the paragraphs here, overall, we see that even for this lower level of social distancing, the impact on the peak, especially for the case where the entire populace does this, is very powerful. And one small caveat that they ended up getting is that once social distancing period ended and everything went quote unquote back to normal, as if there was no pandemic, there was a slight increase of the curve from before the social distancing period. However, it's very easy for us to say that this is still a much lower peak than if you had done nothing at all. One interesting thing to note again, however, is that when we had everyone do it versus a smaller percentage of populace do it, we noticed that the larger percent of populace has a slightly higher rebound when the quarantining is over. And that's something that we'll be kind of exploring more in the next slide or so. But for now, it's important to note that if we just put the quarantine period at the right timing, we can really stifle the growth of the virus and just make sure that the total volume of people infected, as well as the total max number of people infected, gets much lower. Next slide. So in the previous slide, we briefly touched on about how the percentage of people being quarantined had different levels of rebound once the quarantine period was over. And surprisingly, the more people we had quarantined, the higher the rebound was. And this effect is something we can see again when we look at C, D, E, and F, the pairs of graphs that refer to 75% contact reduction and 95% contact reduction. Both of these situations, other than the early quarantining only shifting the curve, had very low peaks during the social distancing period, with the exception of the red curve, which refers to, I believe, 60 and adults. But after social quarantine period is over, both situations had much higher rebounds than the 25% social reduction before. So this kind of led the study to take a look at what might be happening here. And what happened, as it turns out, is that when they're particularly strict during the social quarantine period, what they ended up getting was not quite a reduction of the curve effect, but it looked almost more like it was just moving the curve. And so what ended up happening was when they're super strict about it, it was almost simulating the effects of the early quarantine period that ended up just moving the curve. Fortunately, this doesn't actually happen, and they still saw the peaks go down, but nonetheless, the peaks end up being somewhat higher than you might expect after the quarantine period is over. And in fact, the stricter they were, for instance, the 95% case, actually ended up having peaks nearly comparable to not doing anything at all in the case where we have our entire population social distancing. So the surprising key takeaway from this study from the CDC is that although it is very clear from the second study that we looked at today that if you're going to socially distance for the entire pandemic, more is definitely better. And in fact, we see increasing returns. But if we are to limit our social distancing period to a very limited time within the pandemic, it is actually surprisingly unhelpful to be particularly strict if we're just planning to go back to what was considered the norm after that. And in fact, this might lull people into a false sense of security when they think we were really strict during this time of social distancing, so things are going to be much better now. And in fact, we're so much better than if we had just done a slight level of social distancing, which means we can go back to business as normal, and the pandemic is effectively going to contain itself now. But this is clearly not the case, as we can see from that purple curve being the representative curve for how kind of we've been treating it, where everyone just social distance as strict as possible, and then everything will be okay. This slight discrepancy will be further explored by Andrew as he talks about the implementation in the US, the successes, and potentially the failures.
Yeah, so we just looked at social distancing as one of the potential interventions for flattening the curve. So here's a quick overview of stay-at-home orders that the US has imposed by state. So by the end of April, we saw that 42 states had some form of stay-at-home order or recommendation. 3 had partial orders for certain regions of the state, but not the entire state. And by now, most states have relaxed their orders, but the recent spikes that we've seen in a couple weeks have been reintroducing such mandates. Okay, so next slide. Another form of intervention that we saw was mask mandates. So in this case, 34 states plus DC require mask and face coverings in public. However, there's been a lot of major resistance to the implementation of mandatory masks in many cities and states. So the effectiveness in this as a whole in flattening the curve is a bit questionable, but we'll move on to the next one. So the last one was contact tracing and quarantine. So with this, each state does practice some form of contact tracing, at least they claim to. And it typically involves calling a list of contacts that an infected person provides. So some states also have quarantine requirements when traveling. As we know, like if you went back on campus, for example, to Massachusetts, you had to fill out a form saying you would do a quarantine for at least 2 weeks, or provide a negative test result that can substitute for that quarantine. And some states do impose a legal fine and repercussion for violations of these quarantines. We're not going to get into too much detail about the effectiveness of this, as we saw from the previous group that talked about contact tracing. We saw that its effectiveness was also a little shaky on of the US's implementation. Okay, next slide. So now that we've talked about the ways that the US has tried to flatten the curve, we're gonna take a look at the current progress. So we've been talking about flattening the curve. So this is the curve that we are trying to flatten. As you can see, nothing about it is quite flat. There are about 3 peaks in it, and the third peak, or each progressive peak, is even higher than the last. So it's hard to say that we've been very successful in flattening the curve. Besides looking at the curve of the cases per day, one interesting curve to look at is the US hospitalizations. We said that one of the motivations for flattening the curve was to reduce the number of people using up hospital capacities and equipment at a time. So if we take a look at this curve, we can also see that it is not quite flat as well. There are 3 peaks as we saw previously, and the current peak is just higher than the previous 2. So flattening the curve in this case clearly has not happened either. Another curve that we are interested in looking at is the number of US deaths per day. Obviously, we want this one to be as flat and low as possible. So here we can also see those 3 peaks again, and unfortunately in the past couple of weeks it has been going up. So not very much success here either. So can we go to the next slide? So one important thing to look at is the local level of curves. So these are the curves of states that have had an increase very recently. It doesn't include every state, since some states like Hawaii, for example, haven't faced a large increase. But here we can see from these local level curves that certain states only have 1 peak, and that peak is happening now. So when we think about the US, the total curve of the US with the number of daily cases, we can see that that doesn't reflect exactly what's happening on the local level. So if you take a look at like Wyoming, for example, on the top left, there hasn't been any peak until now. So it's really interesting to see that we can kind of think of these more rural places as socially distanced from where the peaks of the epidemic has been, and now the pandemic is only catching up to them. But yeah, as we can see, flattening the curve has not been successful in many places in the US. And with that, we can move on to questions.
So thank you. I posted 2 questions in the chat. Does anyone else have a question first? Okay, can you go back to the 3 plots you showed about number of cases, hospitalizations, and deaths? So for the, go back one more. Thanks. So this is the number of cases. Is there any, do you know of any similar plots that adjust for the number of testing that's done? Because the more testing that there is, the more cases you will discover.
So there was a plot for the number, like the curve of like the daily tests that the US has performed. And it looks more like a linear kind of line going constantly up, if that's what you're asking.
Well, I'm just trying to get a sense of how to read this. If you go to the next plot, okay, to me that seems a more useful curve because that's not going to depend on the amount of testing you're going to do. And here,
Yeah.
and if you toggle back from this to the previous, you know, you see that the second bump is higher in this curve on what's going on. So it might look like things are getting worse and worse and worse, and then Thanksgiving it's getting even worse. But if you go to the hospitalization, you see, you know, the Thanksgiving is still worse, but the other two are comparable.
Mm-hmm.
And if you go to the deaths, yeah, this could be indicating, what's interesting now is that the second one is actually less than the first. And the Thanksgiving seems to be less than the first one as well, that we now have a better sense of who is at highest risk and have adopted some strategies to protect them. One thing that
Yeah, one of the
oh yes, please.
honestly, one of the things that can be attributed to the decrease in the peaks for the curve of deaths is that the healthcare system has gotten a little more effective in treating COVID, since they now have more information and more research done on potential treatments.
Additionally, there's also been an increase in like the amount of infrastructure that we've sort of like invested into with like as the pandemic grew, because sort of like a big issue that was at the beginning was like we just didn't have enough like resources because we just weren't prepared. And as the pandemic kind of evolved, we were able to get more ventilators and masks and other like PPE and things of the sort that we just didn't realize we needed when it first hit. And then as the pandemic kind of changed, we were able to invest in like the infrastructure of the healthcare system so it could sort of handle the same level or a similar level of hospitalizations and cases.
And there's one other thing I just wanted to comment on. It looks very periodic in terms of it. You have all these little skyscrapers or mountains going up, down, up, down, up, down. Is there anything you can say about this? Is this a function of, you know, when different places report, or?
Yeah, so you can go first.
Well, something that was interesting to us was also just the amount of different, like just the disparities between different states and when like things like reached peaks versus like, for example, like the South started reaching like its peak like way later in the summer than like northern states. And so like a lot of different places sort of just had like a different time when the pandemic hit, and that's part of it. And I think also just, I mean, the Thanksgiving one, like a lot of people are traveling. So there's like a lot of things that could be involved in just this weird like trend and like increases and decreases. But Andrew, I don't know if you have like more insight into that.
Yeah, like with regards to like the periods that these results were reported, like if we look at this graph and we look at like the actual like the bar part of the graph, we can see like the instances where most of these things were reported like in each of those tiny little spikes up. And there are, like, the yellow lines indicate abnormalities in the data because of delayed testing. So these graphs do account for like when the results were reported.
Right, but
That's what you're interested in.
what I'm remarking is that you have a tremendous number of small little, spikes or hairs coming out of the giant mountain range.
Mhm.
Where it goes up and then down and up and then down and up and down, very periodic, where you have tremendous drop in the number of cases from one day and then a tremendous rise a day or two later.
Yeah. Yeah, those can just be accounted to when everything ends up being reported in the week or the month.
Right. And so is it possible that there are some places that don't do daily reports but only do, say, a weekly report on a certain day?
Yeah, I think that's a good question to ask when we're looking at this data, because every state has a different mechanism for counting their cases and reporting their cases. So accumulating it all into a nationwide graph definitely has its difficulties. And that's probably why we have these, like, differences in when the results are reported.
And then we have a question from the class. Can a comparison be drawn with any other countries to help model what will happen with states like Wyoming, which are on a serious upswing for the first time?
So we didn't really focus on other countries. Most of our efforts were only look at the US, but if we were to draw a comparison, at least with what we've seen here with other states and perhaps the other studies, is that if this upswing is due to them lightening regulations, then we'll probably expect this upswing to continue for a little bit, just because if people are loads of false insecurity until things get locked down again, or at least get focused on in terms of regulatory manners, they're going to have issues. And I think rather than other countries, at the very least, we can draw inspiration from other states where once they release regulation for the first time, there is another upshoot, just like in Washington State, where they were initially one of the harsher states, but then once they let go of the regulations, they had a second upswing. And honestly, each upswing is pretty similar in terms of causes and effects, and ultimately the ways that they use to solve it. So odds are they're going to have to do another lockdown, or at least become more strict just how they treat people that are going about their day, as well as people that may be sick.
Thank you. Any other questions from the class? So I will ask the following. You have been appointed to be the advisory council to advise the US on what it should do. And again, when we made the decisions in March, we had a lot of uncertainty. What would you recommend now based on what you're seeing?
I think knowing what we know, and that knowing that it's very hard to actually implement and regulate strict social distancing, we'd probably want to go for a lighter level of social distancing, just to try to get at least some lowering of the peak and then reduce the rebound that would happen afterward. Because from state to state, it's very clear that no state is okay with a permanent social distancing until the pandemic's over. And so it's better to kind of compromise and just say, we want to still have better effects overall. So we might have lighter social distancing. And this seems counterintuitive for people that are clamoring for the harsher methods. But in order to prevent rebound and actually make sure people are complying, I think being somewhat less strict is a better path to go in order to ultimately, the goal is just to prevent as many deaths possible, prevent the peak of the curve, and prevent number of people infected. And if we know that people are not going to listen necessarily to the theoretical level of things, it's better to compromise on the lighter level of distancing.
Another thing that is important is also just taking into account disparities in different regions, because I mean, we see it with the state curves, and we also see it just in general within cities, that some places are able to handle more cases than others, and also some populations might be able to social distance more than others. And so also working with like local governments to make sure that like because there is not like a single answer that can sort of encompass such a broad range of counties, just like the idea of like making sure that we're not pushing something that could be good in one area, but in a different local area, it could actually like not do much and instead like hurt people's chances of going to work or hurts people's chances of actually getting the care that they need. And so just being able to like account for those differences at local levels is really important. And it's something that like the US has kind of struggled with, and like seeing how just very rural places and poorer areas of the United States just haven't been able to handle the pandemic as well. So that's also just something important to keep in mind.
Right, it's extremely important to be clear about what are we trying to optimize, what are we trying to deal with? Are we trying to minimize deaths due to COVID, or are we trying to minimize overall deaths in the US, or are we trying to maximize some kind of net value? Because as you've said, the pandemic is not hitting all sectors of the country equally. I am quite worried about what this is doing for education. Not all districts can handle moving the kids remote. Not all families can handle this equally. And these are extremely challenging things to look at. Thank you. Any other questions from the class? I do find it somewhat appropriate that this talk happened during the maximum social distancing at Williams. As I actually am in our old classroom. I still come here just because I feel more like a professor being in the classroom than just being in my office or being at home. So anyways, thank you again. Have a great day all.